Welcome. Thank you all for being here, for traveling such long distances to join us today. I hope that as many of you as possible were able to be here over the weekend and share some of that delightful New York City weather. We have a very exciting program in store for you this year, and I'm certain that we will all come away with new ideas, new partnerships, and a better understanding of how our companies can make a bigger difference in the world and be stronger and more successful organizations in the process. And we have to do this because as our businesses, as our companies expand in Asia, Africa, Latin America, our obligations as global stewards also expand. We've got to come together and we've got to learn from each other so that we can do more and do better. Now you'll notice that I also said we have to do bigger. And we have to make a bigger difference in the world. And I want to start with bigger this morning because it conveys two important messages at once. First is it acknowledges all the great work that everybody in this room has been doing and is doing today in the field of global health. Between workplace programs for our employees and investments in the communities where we work, we invest collectively hundreds and hundreds of millions of dollars each and every year for the well-being of the people that we care about. And that doesn't count the many hours of volunteer time that our employees dedicate, or the donations of goods and technologies and pro bono services. When you roll that up all together, that is big, and you deserve a lot of congratulations. And many of you, probably most of you, I hope so, are rightly proud of the work that your company does in the field of global health. But you wouldn't be here if you were satisfied. It's one thing to be proud, and it's another thing to think that the job is done. True, New York is a great place to be, and it's always fun to come to one of the world's most exciting and dynamic cities, but there are other things you could be doing in New York, and there are other places that you could be. But you're here because as good as your programs are, you know that by being here you can gain that key insight, meet the partner from halfway around the world you've been trying to see since last year's conference, or learn about new trends in global health and the funding environment that will keep you and your company on the leading edge. You and your colleagues know the potential that building your programs have to making the world a better place. You know that you have the ability to reduce cardiovascular disease by promoting healthy habits and a good diet. You know that you can prevent one more HIV infection by finding a more creative way to talk to your employees about safe sex and risky behaviors. You know that you can spread that to your community and your stakeholders by taking just one extra step and by learning from a company that's gone there before you. And you know that you can save one more child's life by expanding your BedNet program or improving the sanitation program in the community where you work. It's in large part that you know this because of the experience you have with GBC Health. Maybe it was somebody you met here last year, or you heard at one of our dozens of conferences and events around the world over the course of the last 12 months. Now, certainly there's a lot of progress that we can be proud of and encouraged by today in the global health arena, but despite all the progress that we've seen recently, we have a long way to go. A child dies from malaria every minute of every day in Africa because he or she does not have access to a BedNet, a $10 BedNet. Drug resistance in TB and in HIV are looming large and threaten to undermine so much of the investments that we've already made. No business person worth their salt would accept that going forward. GBC Health as a coalition is moving forward in a bold way. New members of our coalition like HP, Dow, Medtronic, and FHI 360, to name a few, have joined stalwarts like Shell and BD, SAB Miller, and Anglo American, and are redefining excellence and providing exciting new programs that we all can tie up with and learn from. A new initiative from the UN Secretary General's office called the MDG Health Alliance has 6 new pillars, each aimed in important ways at engaging the corporate sector on everything from maternal health to prevention of mother-to-child transmission to reducing malaria deaths to near zero. And we're going to hear a lot about that in a special program, a special panel that we have later this afternoon. Cardiovascular and related diseases like diabetes are exploding in the frontier and the emerging markets. Governments in those economies are desperate for partnership from the private sector. Knowing how to navigate those waters, building those relationships with those governments will be key to our success in improving health outcomes over a broad range of issues and over the longer term going forward. The last 3 years haven't been so easy for the global business community. The global financial recession, Occupy Wall Street, everybody from governments to civil society, community stakeholder organizations are villainizing the corporate community for their lack of responsibility or perceived lack of responsibility in our broader society. Richard Edelman this afternoon will tell us about some exciting and very, very important new research that his company, Edelman, has done over the course of the last several months that demonstrates that there is a huge gap in trust between business and the rest of the world. Bridging that gap is key to our success. It's key to our ability as companies to be able to operate successfully in the global markets. Aligning our activities, aligning our priorities, aligning our investments with the values and priorities of stakeholders in these markets is just as important, if not more so, than aligning our priorities and activities with the bottom line of our shareholders. I believe, I could be wrong, but I believe very strongly that we are at the beginning of that trend, not the end of it. What started in 2008 was just a catalyst that has ignited the imagination and spurned the interest of people and changed their thinking about the role and place of business in society in ways that we're just now coming to grasp. Mukhtar Kent, our co-chairman, the CEO and chairman of Coca-Cola, just a small beverage company based in Atlanta, Georgia, you may have heard of, will be with us for lunch today. We'll engage in a dialogue with Mukhtar, and he'll share a little bit about what the world's biggest brand is doing to shape its engagement on global health and how they see the world going forward in that respect. There are many new themes in the global health arena that are popping up. It seems like almost every day there's a new flavor of the month, whether it's drug resistance or maternal health. One of the most important, and I think one of the most enduring trends in our field right now is this approach, what might be called an approach toward total health, in which we really focus on the human being, not the disease. We don't divide a person and define her or him by their disease or their condition, but we take them as a complete human being. And we work to integrate our response in a way that's more cost-effective and more successful in terms of health outcomes. I started with bigger, and my promise to you today is that as you join us and engage with in our conversation and plot your strategy to have a bigger impact on global health, I will be mindful to keep my remarks briefer about global health so that you don't have to sit here and listen to me drone on all day. So with that, we have a lot of work to do. over the course of the next 48 hours. So let's get to it, shall we? Let me begin by welcoming to the stage a group of people who are really, really central to all we do and who have been involved in our fight against HIV/AIDS for many, many years as leaders, each in their own way, and usually in partnership with each other. We're delighted to be able to open our conference with this panel on AIDS at 30 for one reason only, because it's a chance to ensure that AIDS doesn't reach 40. 30 years into this epidemic is just too long. It's unacceptable. We have a little virus, clever, absolutely, that virus is. We have a little virus that we can see with a microscope that has outwitted and outfoxed the smartest people in the world. We are within grasp, as Secretary of State Hillary Clinton has said, and others have hoped, of virtually ending HIV/AIDS. Many of you have done incredibly important work in terms of reducing infection rates and in terms of providing treatment for people, especially those who can't afford to pay for it or who aren't part of government insurance systems. But we can't let this epidemic go on. We're very grateful to the Names Project for sharing these quilt panels. There are too many names on the quilt. We've got to stop that. We've got to not only arrest the trend, but reverse it. Let me bring to the stage three tremendous leaders in the field of HIV/AIDS to help us understand the opportunities that we have going forward and to learn about some of the lessons that we can gain from the past. And thank you very much to NBA Cares, the philanthropy and CSR program of the National Basketball Association for bringing us together and for sponsoring this panel. Ambassador Eric Goosby, a physician, and who was on the front line of the AIDS epidemic in San Francisco in the late 80s and early 90s, the U.S. Ambassador at Large for Global AIDS Response, the person who runs PEPFAR. Brian Brink, Chief Medical Officer at Anglo American, the chairman of the delegation, the private sector delegation to the Global Fund Board. Brian has done, also a physician, has done tremendous work. And last but certainly not least, Michel Sidibé, not a physician, like me, an economist, is somebody who has provided exemplary leadership, both at UNICEF and now at UNAIDS. This lovely young lady, my sister, Tlalane Phofoli, is a frontline hero who is just one of the most exciting people and one of the most exceptional people I've ever met. Tlalane works with Mothers to Mothers, a fantastic program based in Cape Town, South Africa, but with programs throughout the world. She is HIV positive. She has a baby girl who's HIV negative, and she is a leader in her community in the fight against AIDS, and we are honored to have you with us tonight. Thank you so much.
Good morning, ladies and gentlemen. My name is Tlalane Phofoli. I come from a tiny nation of Lesotho. I am HIV positive and I'm a mother. In Lesotho, where I come from, everybody just about knows everybody. And all of us have always been scared of our common enemy, which is HIV and AIDS. 9 years ago, my fiancé got terribly sick. I suspected because I was seeing signs and symptoms of full-blown AIDS, but he had never got tested, neither had I. The stigma was unbelievable. It still is. I was heartbroken and terrified. After nursing him for weeks, I watched him wasted away and he sadly died in my arms. I was heartbroken and scared, but not surprised. Because for as long as I could remember, HIV and AIDS has always been synonymous with death. After he died, I knew I had two choices: to either die a quick death by means of suicide or to take control of my life. And I decided to take control of my life. Therefore, I traveled 430 kilometers to Johannesburg in the neighboring country of South Africa, where nobody knew who I was, because then I would feel much better. That is my story. But I know it's the same story shared by hundreds of other Africans. But all of a sudden, things have changed. There's hope and a future. In just the last couple of years, we have learned that treating AIDS makes it less likely to be transmitted. And last year, UN announced the global plan to eliminate pediatric AIDS by 2015 and keep mothers alive. 2015, it's 3 years from now. For me, it was a miracle. For so long, there has been too many obstacles to preventing mother-to-child transmission of HIV. The stigma, discrimination, and lack of treatment. There are way too many people who need treatment, but there are very few people providing the treatment. In fact, almost of all new HIV pediatrics infections happen when a mother is pregnant, in labor, or when they are breastfeeding. But almost 100% of these infections are preventable. Here in the US, you have achieved that. Less than one baby is born a day infected with HIV, but in Africa, over 1,000 are born infected with HIV. It's unnecessary because HIV and AIDS is preventable, and it really does break my heart. Without early detection and treatment, 80% of children living with HIV will die by the age they are 5. With treatment, mothers everywhere can celebrate Mother's Day just as we all did. We are at a place where we can reduce mother-to-child transmission of HIV by 90% and maternal deaths by 50%. I know how important it is to protect the health of mothers living with HIV. I empower them with knowledge and tools they need to protect the children and the families as well. As a mentor mother for Mothers to Mothers, I get to do that every day. I have become a role model in my community while all I help my sisters to save their own lives and that of their babies. We are so close to making sure that no baby anywhere will be born without a future. Yet, with the weakened global economy, there is a danger of being stuck just as we are so close to reaching or making the impossible possible. We come so far. Soon your children and mine will never know a world with pediatric AIDS. it can be something that will be found in the history books. It is not time to stop fighting AIDS. It is time to push across that finishing line. In Lesotho and throughout Africa, we are all aware of the power of business. Global companies work extensively in Africa, and you have the power to make huge impact and positive change. The work GBC Health is essential, and I'll thank you all for what you do on our behalf. I'm so honored to introduce this panel of extraordinary leaders in the effort for improved life, because they are the people who care, and they are making a difference, a huge difference. I know that together we can make the global plan goal to eliminate pediatric AIDS by 2015 and keep mothers alive a reality. Thank you.
That was her first time. This is Tlalane's first visit outside of Africa, and it was her first time addressing a group like this. What an inspiration and what a humbling performance. You guys have big shoes to fill now. Tlalane, thanks so much. Let's start out. I'm going to come to Brian Brink second to hear some more about what's going on in South Africa and the African continent. But I wanted to start with Eric Goosby because before he took over as head of PEPFAR, and even before his work in the Clinton administration, where he was working on the U.S. domestic HIV/AIDS programs in response to our own crisis, Eric was a physician on the front line in the epicenter of the U.S. epidemic in San Francisco. And I think it's really important for all of us, many of us from the North and the West, to understand and to recall what those times were like. And so, Eric, if you could take us back a little bit and tell us what you were facing as a physician and the sense of loss and the sense of opportunity lost when you were engaging in this work.
Well, thanks, John. It's really wonderful to have heard Tlalane Phofoli's comments. Thank you for that. I guess I would say that the issues that confronted us 30 years ago were much the same as the issues that confront our colleagues in countries now, who are at an earlier stage in responding to their epidemics. The commonality of the reaction, limited by kind of the spectrum of human reaction, has struck me many, many times as a deja vu repeating of the same issues of being confronted with an overwhelming wave of morbidity and mortality that initially was dominated by fear because we didn't know what it was, we didn't know how it was spread. We thought it might have been aerosolized. We knew it was bloodborne. It wasn't until 1984 that the blood test was made available. That was 3 years after we had been responding to it. I think that in the early days, our toolbox contained really early and efficient diagnosis of opportunistic infection. We would be able to get an individual through 2, 3, 4 infections, all of which were life-threatening, and then the 5th one would kill them. Those that did not die to the opportunistic infections would succumb over a longer period of time to just the ravages of the virus itself on multiple organ systems. I think the hope became one of the main instruments in the toolbox to respond to it, to be there with the patient, with the person, through their opportunistic infections, convening their families each time because you thought you might lose them. You began to know and understand their broader community. You saw the conflicts around the realities of sexual preference matched with families' expectations, the lack of clarity or untruths that had been very much part of the early epidemic in gay men, and the conflicts that were created often at the bedside with the parents realizing the implications of what their son usually was going through, the partner, the dialogue around withdrawal of care. That's what dominated the early epidemic. I think that 500, 600 of my own patients succumbing to the infection, having convened that process, we all saw ourselves moving into an avoidance behavior after 7 or 8 years. I was the director of the AIDS clinic at San Francisco General and had done a lot of research with AZT and DDI, DDC, 3TC, D4T, shiitake mushrooms, Chinese watermelons. We looked at it all to try to see something that stopped viral replication. But the AZT, DDI, DDC, 3TC, D4T period came in, AZT in the 86 to early 90s, the others in the early 90s, were all fraught with side effects that were bad, often made the person feel worse than the disease, and did not sustain suppression of viral replication for about 18 months. You prolong life for about 18 months. Monotherapy, dual therapy, that was what those early years were about. I think that looking and watching how our colleagues in country, physicians, nurses, healthcare workers, respond to the epidemic now have many of those features of being overwhelmed with the morbidity and mortality, having a small toolbox to respond, and it is extraordinarily gratifying, and most of my current motivation to have and be involved in bringing highly effective antiretroviral therapy to populations to benefit and move back onto a life trajectory that really should have them die from something else. All those lives in the early years that did not receive that care remains the core of why I get up and do it every day. Yeah.
There are a lot of people, all of us included, are glad that you get up and do what you do every day, and are very grateful for that. One word that you used that I think is really important here for everybody to keep in mind is déjà vu. We should be doing everything possible, everything we can imagine to avoid déjà vu in 2012 when it comes to this epidemic. I mean, as a young gay man growing up in the Middle West of the United States, a very conservative area, a very conservative part of this country, the stigma in particular about surrounding HIV was deafening for me and for a lot of my friends. And it's the same even for people who are on ARVs. It's in Africa, it's the same type of thing, and it's your medical condition becomes one of many things that you struggle with. And I think one of the most important things that we can do is to really focus on human rights and on acceptance and on love for people who are HIV positive. Brian Brink, as I said, is the chief medical officer at Anglo American, and very quickly the AIDS epidemic shifted in terms of the epicenter and ground zero, and it's still in South Africa in many respects. tell us about the decision-making process at Anglo in the early days. How did you become involved in all of the amazing work that Anglo does? And how did you, and tell us about how you made the decisions.
John, it was difficult then. Up to close to 25% of our workforce was HIV infected, and employees were beginning to get sick and die. And it was despair. Treatment, as Eric described, started becoming available. We didn't really know whether it worked. We knew it cost a lot of money, but we had to do something. And I remember that decision. It was agonizing. We went over it almost for 2 years. And when that decision was finally made, where the company said, we will provide access to AIDS treatment free to all our employees, it was a complete leap of faith. We didn't know what it would cost. We didn't know whether it would work. We just felt determined that something had to be done. And I remember having a list of some 30 different questions which remained unanswered. And the critics would say, but what about this, and what about that, and what about the other thing? And in the end, we just said, well, we're just going to do it, which we did. And as we look back now, that was 10 years ago. It was one of the best decisions our company ever made. You know, what for me was extraordinary was the conviction that came from the businessmen that were miners, were financial people, and didn't fully understand all the implications of the medical problem. But they knew that there was something wrong and that morally someone had to take the lead to show what could be done. And right from those early days, that support from the management, from the leadership of the business was unequivocal. It was always there. And that's really what made the difference, the leadership and the sheer determination. When we look back now, we find that actually that investing in treatment for AIDS actually saved the company money. It didn't cost the company money. So all of those worries, how would our investors react, and so on, it all just melted away. In fact, the response from the outside world was completely unexpected and overwhelming. Instead of being critical and worrying about the business, they actually turned around and gave us support which just was incredible. It actually took us all by surprise that it should have been so widely recognized that a business would get out there and do something for humankind. That's a really important lesson.
Brian probably doesn't remember this, but I'll never forget it. Back in 2004, I believe, I had just started an organization called Transatlantic Partners Against AIDS, which we then later merged with GBC Health. But I attended the first GBC Gala dinner in Washington, D.C. at the Kennedy Center, I think it was. And I was very fortunate to be seated next to Dr. Brian Brink. And he very kindly tutored me for the entire course of that meal in how to fight AIDS and what was important and what Anglo American was learning from its own experience. And it was something that I'll never forget, and it saved us, that one conversation saved us countless hours of time and missteps, and so we're very grateful, always be for that. And we've had a tremendous partnership ever since.
One thing you might not remember, John, is that just before that dinner, Richard Holbrooke had been out to South Africa, and he had toured around our mines, and he had toured countries in Southern Africa. And he was one of the people who said, you've got to get on and do this.
Yeah.
And he gave a bit of a push to our business management as well. And I'm always grateful for the insight that he had. He could see what had to happen. Yeah. And it made a very big difference. So GBC was active way back then. Yeah.
Michel Sidibé, one of the great heroes, we should all be envious of Michel for many respects, for many reasons, one of which is his frequent flyer balance on many of the world's biggest airlines. He travels this planet tirelessly, fighting HIV/AIDS, charming, cajoling, twisting the arms of heads of state and heads of governments, reaching out to the people who are affected by this disease. UNAIDS is one of the treasures, one of the jewels in the international community. Michel, thank you for being here. When you look back over the last 30 years, and you saw this from your period of time at UNICEF and now at UNAIDS, what are the big wins and what worries you most?
You know, John, let me start by saying that when you have people like Tlalane, you cannot stop fighting because this is the face of this epidemic. She is just telling us that it's not numbers, it is families, it is women who are suffering, it is her who is fighting to make sure that she can really accompany her children. So for us, it is not just traveling, it is a duty, it is a commitment for those people without voice. We have to remember, of course, that 30 years ago, it was a gay plague. It was to be HIV/AIDS, it was a shame. People were scared of each other. It was full of stigma, discrimination. But what we learn is that the story of, at least the story of HIV is a history of social movement. Social movement who have been fighting certainly prejudice. Social movement who stop social injustice, calling for redistribution of opportunities between the North and the South. But more than that one, we have to remember that just a few years ago, no one in this room could have believed that we could put people on treatment. Yeah. People, I remember when we were even negotiating the declaration in the General Assembly, people were saying, we will not put treatment for poor because it was too costly. Those days, we were talking about $15,000 per person per year. Today, because public-private partnership, because research and development, because the fight of civil society, we're talking about $80 per person per year. That is a victory. It is not just the victory of science, it's a victory of a social movement which has been generated by HIV/AIDS. So today, we are talking about almost 7 million people on treatment. So I think what I want to say is that we have to remember that one of the most important success story is that we brought AIDS on the agenda of policymakers. We managed to certainly broke the conspiracy of silence. And I said again, the conspiracy of silence. And for me, that is the beginning of whatever we have been able to achieve until now. But also, you know, it's difficult. People were telling us that prevention will never work. I remember we were just talking about Uganda, Senegal, and Thailand as the success stories those days. Today, we're talking about almost 60 countries in the world who have been able to stabilize the epidemic, even to reduce significantly the number of new infections. So I want to say those are the lessons we have been able to learn from these 30 years. I don't want to, again, I am optimistic, and I believe that if we call for zero new infection, zero discrimination, and zero death, is because I believe on this social movement.
Great. Thank you. Eric, PEPFAR partners with a lot of businesses, and many of them in this room. And you guys work very diligently to create strong public-private partnerships. I'd like to hear from you a little bit about where you see the programs at PEPFAR going over the course of the next few years. And in particular, I think it was at the end of last year, actually, Secretary Clinton made a big announcement. It was on World AIDS Day, I believe, and made a big announcement about the ambitions of U.S. government policy in terms of an end to AIDS. And all of that was predicated on this new realization that treatment and prevention are really one and the same thing. And that when we think of treatment as part of a preventive strategy or part of a prevention strategy, all of a sudden we open up new possibilities in terms of strategy. So I guess two things. One is, how do you see that unfolding? And two, what about the prospects for public-private partnerships in the PEPFAR and broader USAID arena?
Well, I think that Secretary Clinton's last November, as you say, John, her speech that spoke to an AIDS-free generation really would be predicated on three pillars of activity. The first is that our combination prevention strategy moves our portfolio of prevention interventions to those prevention interventions that are of high impact. The science really is there to understand the relative contribution that one prevention intervention, be it condoms, be it male circumcision, be it prevention of mother-to-child transmission, or as you alluded to, the role that the use of antiretrovirals play in dropping infectivity. All of those findings now deeply inform, or should inform, our portfolio of services that we support. Moving away from lower impact to high impact prevention interventions, strengthening our male circumcision, our PMTCT, and taking full advantage of the role treatment plays in dropping incidence prevention are the strategies that we have shifted to. With that, we're able to take out with models a trajectory that shows a precipitous drop in the number of new infections globally that will occur as we move into the 6 to 10 million people on antiretroviral drug. We kind of reach a critical mass, like if in this room, 10% of you are on antiretrovirals, 20%, 30%, 40%. There's a point at which the herd type immunity, if I could use that a little out of its definition, but a form of herd immunity occurs when the high-risk behavior does not result in a transmission because the overall level of virus in the community has dropped enough that your risk of getting infected with the virus drops with it. Somewhere around 70 to 85% of people who are HIV positive on antiretroviral drugs, that phenomena occurs. In many of the countries we're in, we're seeing a slope of decline in number of new infections to begin to approach. There are more people going on antiretroviral therapy than are becoming newly infected. When that moment occurs, and I think we're a couple of years away from it, the slope becomes very steep and the number of new infections drop, and I believe that will, by definition, be the beginning of the end of HIV.
That will be a happy day. Mm-hmm. And how about public-private partnerships and their role in PEPFAR and broader U.S. government global health programs?
So as we have looked at what is needed to not be a donor coming in and giving resources to a country to scale up their treatment and prevention services, we look at those structures that need to be in place to support our implementing partner governments at both the national and the provincial level and the district level. The entities that are often best positioned to go all the way out to the district level are those companies that have corporate interests in those same communities, employ those same people, and care for their families in those same communities. They are in the best position to use their core competencies in management, in monitoring, evaluation, and procurement, distribution, to make a profit, to support our ministries at provincial and district levels to expand their capacity to manage, oversee, and run these programs themselves. We believe that the public-private partnership is an additional tool to introduce that support, which makes these programs more sustainable.
Brian, speaking both with your Anglo American hat on and then as also the board member for the private sector delegation and a real just kind of speaking from a broader corporate perspective, you've got two fellas here who control or influence billions of dollars of budgets each year, and who run and design, the world's biggest programs on HIV/AIDS. From your point of view, how important are these? How important to the company? Let me put it this way: to the company and to its bottom line. You alluded to it earlier a little bit and said that the HIV treatment, saves money overall. It doesn't cost money. But if you could talk a little bit more about that, and then what do you need, and what has been your experience in working in large public-private partnerships, and what does the corporate community need from donors and partners in order to make these a success from the business perspective?
John, let me start by looking at the cost of AIDS from a business perspective. We know that the real cost of AIDS is in reduced productivity, absenteeism in particular. That's about 40% of the cost of AIDS. There's the cost of when people get sick and die of having to pay out extra benefits. That's another 40%. And then having to recruit new people and the loss of skills. That's 5%. The actual cost of treatment is 5% of the total. It's a small part of the total cost of AIDS. And so we know in the business that by investing in treatment and in investing early and effectively, we contain the economic impact of AIDS on our business. It's a no-brainer. You just go and do that. It's such a no-brainer. You do it for the employees, you do it for the families, and you just make sure that it works. The point I really want to make is that if that's how it is for business, then equally it's the same for a country. And countries equally themselves must start investing in effectively dealing with the epidemic, because they're going to bring down all the associated costs. And a hugely important thing is to get on and do it early. Why run the risk of waiting for people to get sick, to get TB, and to incur all those extra costs? It's a complete waste of time and money. We must just get on and get the job done. And I think that's where businesses at least can show the way, because we understand the economics and we understand what that does for the country as a whole. If we want to create business opportunity going forwards in developing countries, and that's where all the growth is going to be, we've got to get rid of the burden of disease and unshackle all the potential in those economies. Now, I think it's profoundly important that we do it within countries ourselves. We can then look to the bilateral donors like PEPFAR, or the multilaterals like the Global Fund and others, and the technical assistance of UNAIDS. There's lots of help that we can get in those partnerships, especially in communities. There are lots of weaknesses in the health system which need to be fixed. And those are the sort of sustainable interventions that we can get some help with. But we can't ask these donors to come and pay the cost of the ongoing treatment costs, because it's just not sustainable. And they don't need to, because it's such a good investment anyway.
I'm going to make a confession here. I got a B in accounting, even though I went ahead and got a doctorate in economics. I didn't let that stop me. But in business terms, the costs of goods sold, i.e. the providing antiretroviral treatment, is 5% of the overall cost of saving someone's life and keeping them at work, right? In other words, it's 18 times roughly more expensive not to treat HIV in the workplace than it is to provide the treatment and the prevention programs. 18 times, at least that's Anglo's experience, and for others. And my bet is that the vast majority of companies in this room today have an HIV program someplace, at least in hot spots where you work, and are doing great things. But I would also bet that there's a big win that we could achieve by tapping into and using that math, that logic, with our supply chain. How many of us have contractors, whether they're in Africa, Southeast Asia, Latin America, wherever, who might not have an HIV positive or an HIV prevention or treatment program? And how could we, with a simple phone call and one meeting, convince them to become engaged and to extend basically what we're doing, teach them, share with them our experiences, and to help them move a similar program forward with their own workforce? That would be a tremendous savings, not only for that company, but for you as well in the longer term, I bet. Michel Sidibé, you're going to come back to the United States in July for the International AIDS Society Conference, and I think that we're actually doing a big thing kind of together at the Kennedy Center with a concert, and AmFAR and GBCHealth are having a major event there. Question that constantly comes up in my mind, because the HIV epidemic in this country is far from over. What should we and what should Western Europe and other wealthy regions be learning from the global South and our experience there about HIV and effective ways to curb the epidemic?
John, I think that is a very important question. I will say three things. First is probably to not just consider HIV/AIDS as a disease, and trying to look at it as an opportunity to certainly deal with difficult issues like human rights issues, opportunity certainly to bring a debate around integration instead of keeping AIDS in the corner, trying to deal with AIDS as a part of a systemic issues which will help us to reduce costs. If you look at, for example, today, you can see the clear linkages between maternal mortality, child mortality, and HIV/AIDS. You can see the link between tuberculosis and HIV/AIDS. You can see the linkage between HIV and cancer. So take AIDS out of isolation, making sure that we reduce costs. We look at it as a part of the response to the global health and not deal it in isolation. I think that is a first lesson we learn. The second lesson is that we are more and more convinced that we need a different, and that's where business can help us, different innovation to be able to go to scale. Yep. Innovation and access is critical. I think we are seeing more and more that the technological innovation which we are having today is difficult to be owned by people. It's very important to democratize the problem solving, to think about certainly a new technology which will help us to test those 10 million people who are waiting, for example, to know their status, to start their treatment, at least their CD4 level. If you take the CD4 machine today, it will cost us $700 million just to test them with those machines. And today we are seeing new innovation, new technological research, which can help us just to take the blood and in 1 minute, 3 minutes to know if the CD4 is above 350 and if this person should initiate. With this type of simple technology, we can certainly tap on non-conventional capacities in African and different place and go to scale and reach people, and it will cost us $10 million because this technology will cost less than $1 to be able to reach those people with that one. So that is how to reduce costs, how to make sure that we become more cost effective is very important. And lastly, I think in Africa, and particularly in developing world, what we learn is that we need a different a business framework in terms of investing. And we need an investment framework which can really enable people to have a maximum of return on any dollars they are investing by better prioritizing, by making sure that they have better targeting and intervention which can have a maximum of return. For that intervention, I can just say that stopping babies born with HIV and keeping mother alive is certainly one of those interventions with high return with a little investment.
Great. Eric, are there things that you take from your PEPFAR experience and say, I've got to go talk to Kathleen Sebelius, I've got to talk with U.S. mayors and share these lessons?
Yes, there are. I think that President Bush, in his wisdom in setting up the PEPFAR program, understood how bureaucracies work. And one central piece to successful control of a program is having the control of the budget. Without that control, your ability to influence and prioritize activity is diminished. I think President Bush set this program up so there was one central coordinating function that then worked through existing agencies to implement. That lack of that clarity in the domestic response has diminished our ability to keep focused on those elements in the population that are participating in highest risk to prevent movement of the virus through those populations effectively. That's something that needs to be sustained, not for 3 months, not for 2 years, but sustained. That inability to keep that rigor has given a waxing and waning implementation strategy to the domestic response, which has allowed for cracks and seams. I think the other confounder has been that HIV in the domestic epidemic is a gradually increases a person's going from kind of private insurance to public systems. And that transition has not been smoothly laid out and a glide path created so it's really seamless and easy from a patient's perspective to negotiate it.
See, Brian, from your perspective on the Global Fund Board, Eric at PEPFAR, and Michel, from a kind of a global multilateral agency perspective, you all have your fingers on the pulse of this question. Where do you see that headed, and what do you see are the implications for, say, the next 5 years? Michel?
No, I think personally it's very important to pay attention to sustainability because all our gain today are very fragile. Whatever we can say, we have been able to put people on treatment. We scale up the programs. We have mobilized resources, but we are seeing also a kind of stabilization on the levels of resources. So it's important to be innovative. We need to start thinking about shared responsibility, looking on opportunity for discussing domestic budgets or how we can have a bigger proportion of domestic budget to support the response, because today in Africa, 90% of the people who are on treatment based on resources coming from PEPFAR or Global Fund, so which is not sustainable. So what we are doing now is to open a new debate with African leaders to make sure that we can have a roadmap to look at what could be innovation in terms of mobilizing resources locally also, and also thinking about more long-term approach in terms of thinking, for example, on mechanism which has been introduced in Rwanda and different places, which is kind of supporting poor people to have access through kind of security scheme programs, which will be helping them to have access to long-term treatment programs. So those are few things we are trying to look at, and we're working on it with different leaders, and I think it's important. Of course, meantime, we need to continue to mobilize through global solidarity more resources.
Brian?
John, what's important about the Global Fund is it's a partnership. It's the one multilateral institution that has governments and the private sector and civil society all working together in this funding mechanism. It's an extraordinary opportunity. The fund is quite new. It's just turned 10. It's going into its teenage years now, and there's some difficulties we all know. But it's working out new models of funding. And in fact, at this last board meeting, probably the most important thing coming out is that there are now going to be new funding opportunities, which are not going to be like the old rounds that we had, which was a sort of a jackpot, see how much you can ask for and how much you can get. Going to be a much more measured kind of response, country by country. Let's look at your strategic plan. Let's look at who's doing what. What is the government putting in? What is private sector putting in? What are the bilateral donors putting in? Where can the Global Fund come in? How can we all work together now to make sure that that country plan for dealing with AIDS is realized? So the Global Fund is just profoundly important. And it truly is global. It gets to 150 of the poorest countries around the world. Business needs to take note of the importance of that fund, because that is the fund that is reducing the burden of disease in developing countries and creating the environment to go and do more business once that has been removed. So it's a long-term investment. I really hope we can see more and more businesses getting involved and realizing what can be done.
Thank you. We're going to hear from the new managing director of the Global Fund tomorrow evening. And he comes from the private sector, from a finance background, and we very much look forward to that. Eric, last word to you. What do you see about in terms of global funding trends and the opportunities and risks inherent in the ebbs and flows of those funds?
Well, I would really echo both of my friends and colleagues here's statements around sustainability. I believe that we really have come to a moment in the global discussion where we realize that vertical program funding, such as in PEPFAR, in HIV, in HIV-TB, in malaria, give you an opportunity, when funded, to infuse those resources into countries, translate those resources into programs that can have a profound impact on morbidity and mortality. I think that now we need to acknowledge that those motors, that those vertical program resources created to address those diseases are realized best really in the shared responsibility conduit that the Global Fund presents to us, where instead of a country having to have a bilateral response, there's now a resource of monies that converge from countries, from business, from the implementing countries themselves, that are taken to address those unmet needs in a way that allows even countries that would never have a bilateral program to contribute to the solution. These big types of motors, like Global Fund, like Gavi, are really, I believe, a central piece on the topography of the global health stage that will remain because of their effectiveness in allowing others to contribute to the solution who never would be able to in and of themselves, and to have our implementing countries as the convener of these divergent resources to orchestrate and define unmet need in their countries and make those allocation decisions. That model of bringing resources in, convened, orchestrated, and implemented by the country itself, held to a high level of accountability in the delivery of the outcome, the adherence to the science, and the nimbleness to change as those needs of the population who uses these services change, really is the future of global health. And I believe the discussions for putting a basement of health care on the planet, this is the beginning of that. And it is through organizations such as the Global Fund, et cetera, that this will be realized. So I think it is one of the most exciting times in global health. Even with flat funding, we have exponentially increased the number of people who have benefited from these services. And we'll continue to do that because we are getting smarter and better at what we do. The final piece of that is the importance right now of operational or implementation research. Our ability to understand what we're doing, and most importantly, the impact of what we're doing is now in front of us, and we need to embrace that and see that as a legitimate investment. So,
Thank you very much. Please join me in thanking these three tremendous leaders.
Thank you.